guest this morning is Dr. Keva Thompson. She is newly minted Director of Planning for the Public Hospitals Authority, and we are very pleased that she's here with us today. She and I go way back, and so I know she will do an outstanding job as she presents this morning and tell us a little bit more about how COVID-19 has impacted our health system. Let us welcome Dr. Keva Thompson.
Thank you very much, and good morning to all. Thank you for having me. I'm here. My task this morning is to speak to you about the COVID-19 pandemic and its impact on the Public Hospital Authority services. I have to admit that I took some liberties. My original task was to look at its impact on diabetes services, but I expanded the scope of the presentation. Next slide, please. Okay, so let's talk about the COVID-19 pandemic. So while it was initially seen as an epidemic in China in late December, early January of this year, it quickly became a disease of public health importance and then a pandemic within months. So by mid-March, the World Health Organization would have declared it a pandemic, meaning it had spread around the world. And by the end of that month, we would have already recorded 500,000 persons infected and more than 30,000 deaths. By September 29th, the world recorded 1 million deaths. And if you look at the slide, you will see where we are as of November 10th, where we have over 50 million confirmed cases and 1.2 million deaths. So let's bring the epidemic home to the Bahamas. Next slide, please. Again, in December, the disease was first identified in Wuhan, China, Hubei province. By January, the end of January, it was announced that it's a disease of public health importance. And by the beginning of mid-March, it was declared a pandemic. The Bahamas confirmed its first case on the 15th of March, 2020. And by April 13th, we recorded our first death. And by the 26th of August, we experienced our deadliest day with more than 17 deaths in country. So let's think about the Bahamian context for the pandemic. We've heard the statistics. Let's bring it in a little closer and start talking about what this meant to the Bahamian people, the Bahamian government, and our healthcare services. Okay, so I borrowed this slide from my colleagues at the European Center for Disease Prevention and Control. And what they did was they graphed our government action by our cases. So on the 15th of March, we closed schools, the government closed schools. By then we were recording 1-2 cases. By the time as we hit 2 cases, the government began thinking about what economic responses would be like. And by the 20th of March, we began our nightly curfews. I'm sure everybody remembers. By the 24th of March, I think we were around 5 or 6 cases, and then we started our 24-hour curfews. And the previous slide showed what the streets looked like. Nobody was on the streets. And we closed the country. We closed the airports and the seaports. We didn't allow anybody in. And by the 30th of March, the government again started speaking to us about what economic procedures were in place. By then, persons were losing jobs. We were somewhere around 14 or 15 cases. And at this point, everything was closed. Next slide, please. So what does lockdown mean to health services? You know, we've heard a lot about what lockdown meant to the individuals. I'm home, I'm stuck. What does it mean to services? So I'm here to talk to you about what this means. Next slide, please. So in the early days of the pandemic, the Public Hospitals Authority began rolling out strategies to try to mitigate the spread of the disease in our institutions. And so we closed our outpatient services. And I heard my colleague in the back talking about what that meant for him. We started canceling elective surgeries. We repurposed our healthcare workers, meaning we would have removed, if you were working in outpatients, we moved you to the entrance to do some of the screening, or we would have redeployed you to contact tracing, or we would have redeployed you to the call centers. We also strengthened our supply chain management services. We wanted to be ahead of the curve. And when I say ahead of the curve, what other countries were experiencing at that time was shortages of personal protective equipment. And so we began plotting and projecting what supplies of PPEs we have and how long it would last us. And so you would have heard the then minister speak to you about the burn rate. So we started calculating the burn rate. We also took the time to beef up our medical and surgical supplies to ensure, and our lab supplies to ensure that we didn't run out of these needed supplies. However, supplies were short. There were times when we had short supplies. No, not quite any stockouts, but short supplies. We also enacted our surge capacity protocol, and this is the protocol that we roll out when there's a major event. We would have, all patients who we consider less critical, we would release them. So the hospital at that time was virtually contained or empty. But we also took note of changes in the health-seeking behavior of Bahamians. And by health-seeking behavior, I mean, if you have a flu, if you have a cold, will you come to the hospital? Will you seek care? And we noted that that changed. And so I'm going to walk with you what happened following the wake of these closures and lockdowns. Next slide, please. So let's look at the emergency medical services. And my period of reference right now is January 2019 to August 2020. So you would note that I talked to you about the first case being identified in March. So around here, March, by April, you would see that we clocked a 40% reduction in emergency medical calls. And that's for Princess Margaret Hospital. In Grand Bahama, we would have seen a 20% reduction in EMS calls. And in Abaco, we saw only slightly a 1%. And we know Abaco this was on the heels of Dorian, and many persons didn't have a car, so we didn't expect to see a reduction in their calls for EMS services. Next slide, please. Okay, so let's take a look at accident emergency services. Again, the period of reference is January of last year to August of this year. And so I want to show you a dip in Grand Bahama, Dorian, and you would see a concomitant increase in Nassau. So where the people left Grand Bahama and Abaco, A&E went down. In Grand Bahama, in Nassau, it went up, right? So in Nassau, our accident emergency recorded a 37% reduce in persons showing up, and in Grand Bahama, a 39%. So we stayed home 2 hours, sometimes to our detriment. Next slide, please. Inpatient services. So we also saw, as I said, when we do a surge capacity protocol, we send people home. So the hospital was empty. People weren't showing up as they typically did, a fear of COVID, and rightfully so. But we saw a 12% reduce discharges at PMH. We saw a 32% reduction for the Rand Memorial. And for Sanderland Psychology Service, we saw a 23% reduction. Next slide, please. Surgical volumes, as my colleague said. 2020, shorter line. You would see in April and May, nobody was having any surgeries. We only did emergency surgeries, no elective surgeries. And as the disease and the cases went down, we started up again. And around August, we started to see more diseases. So you would see our surgical volumes decrease. And during this time, just because I needed a surgery and there's COVID, it didn't mean that I don't continue to need a surgery. My disease is progressing. Next slide, please. Outpatient services, we also closed our outpatient services during massive community spread. And so we would have reported at that point, I believe, a 48%, sorry to take that back, 28% reduction in outpatient services. So some services continue, but our specialty clinics were closed. Next slide, please. So the reason I made the point that my disease might be progressing, during this time, we saw an increase in the number of deaths. And I'm comparing the deaths over time from 2018, 2019, 2020, and we recorded a, let me not misspeak on this one, a 38% increase in deaths at PMH and a 19% increase in deaths at Rand Memorial, and at Sandalwood we would have reported a 100% increase in deaths. And I wanted to say, not to panic. Sandalwoods don't typically record deaths. So if you get sick and you're in Sandalwoods, we would ship you out to Princess Margaret Hospital. But because we were having spikes in cases, Sandalwoods was left to manage their COVID cases in-house. Some of them were sent to PMH, but some of them stayed at Sandalwoods, and so they would have recorded a 100% increase in deaths. Now, they have a geriatric, Sandalwoods is a 3-hospital in one. Sandalwoods have a geriatric hospital, Sandalwoods have a psychiatric hospital, and Sandalwoods has a drug addiction service hospital. So we experienced in the Sandalwoods during our second wave an outbreak in our geriatrics, psychiatric, but not our drug services. Okay. So while all of this was going on with our services and in the population, people dying, and not necessarily due to COVID. I believe the national persons would have already speak about excess death due to COVID. I'm not going to touch that. I wanted to talk to you also about our human resources. So as caregivers, we are as exposed to COVID-19 as our clients. And many times we have clients who visit our institutions who are not sure of their status. And I heard the hospital administrator only yesterday explain to us that yes, I give you a COVID test and you are negative last week, but by the time as you come to me this week, you may be positive. And so, next slide. This is a look at COVID positive employees who would have become infected or been exposed in our institution. And you can see from August 12th to September 15th, PMH reported 80 of our staff that were positive, Grand Bahama 49, and Sandalwoods 31. So the COVID pandemic has had an impact on our carers as well. Next slide, please. So we reached a point in time where the World Health Organization has called us or has provided us with a mandate, and it says we are in the new normal and we are required as an institution to provide care. We have to organize ourselves, we have to learn from previous experience, we have to rely on our knowledge of infection prevention and control, and we have to provide care. And so in light of that mandate, next slide please, the following global trends have been identified. In other jurisdictions, as in the Bahamas, we have had to learn to leverage the potential of telemedicine, and we'll get into that. We've learned novel supply chain and medicine dispensary options, and we'll get into that. At PMH, you can WhatsApp your old prescription, and you can say, I need this refilled, and someone will give you a call or text you back and say, come pick it up. So we've had to learn to do things a little different than having people queue up for services. And we've also had to engage the private sector. You can go ahead and get COVID testing now in the private sector and in our communities. And the World Health Organization also said to countries of the world, they provided a guidance tool for us to say essential services must continue. And so this is the area that we find ourselves in. Next slide, please. But before I get to what we did as an organization, let me talk to you about what our concerns were. There's a context to everything. So administratively, we have had to deal with the exposure of our frontline workers. We have grappled with teleworking responsibility. When everybody was home, the wheels of the government, the wheels of the hospital had to churn. So we grappled with teleworking, we grappled with the productivity of people when they're home. We have struggled with infection. Some of our, as I showed you before, some of our workers have tested positive. And we have an employee health services that manage our workers who are positive. And you're aware that thus far, I think we're now at 5 deaths for healthcare workers. So we've had to manage employee concerns, their deaths, and their anxiety. So that's what the PHA has had to manage administratively. Clinically, we have a whole bunch of concerns. We have limited capacity. We exist in hospitals that are older, aged, and facilities that are not up to code for today's healthcare. And along that line, we have found ourselves overrun with a surge of persons needing to be tested for COVID, and those are called persons under investigations, or PUI. We've had to boost our lab capacity to churn out all these tests. I hear the public saying very often, test, test, test. In country, we have limited lab capacity. We're growing and we're learning as we grow. Again, we have significant human resource deficits. To provide care for these clients, we also need to have negative air pressure, and we had very limited spaces like that. We've had to close wards due to exposures, and we've had to boost our capacity for ventilation and airway management. That's the context that we work in. Next slide, please. So in light of that, NCDs are non-communicable disease. We've innovated, the healthcare system has had to innovate and move to digital management of these non-communicable disease while our system is grappling with COVID. Next slide, please. And so what could we achieve from these digital solutions? One, they are complementary, overall they're complementary to in-person care. And so the World Health Organization say that these digital solutions can support the maintenance of continuity of service during a period of community transition. So if we're in a high transmission rate and I need to see my doctor, I see Dr. Farkas in the back there, I can call him and I can use a platform and I can say to Dr. Farkas, I need you to take a look at my feet, tell me how things are. And we have rolled out such services. We need to enhance our communications between the provider and the patients. Oftentimes I have another slide where we talk about when people call, what they're calling about. People call and say, I need to talk to my doctor. And so we've had to innovate and make our doctors available to take those calls. And most times the persons on the call are nurses and doctors. We've had to improve the continuity of care. We have to promote, or rather this digital solution will promote autonomy and self-care, because as patients we have responsibility as well for our care. And we have seen higher degree of adherence to our treatment when we're able to say to the doctor, hey, the medication made me dizzy or something, and he was able to correct. Next slide, please. So what type of intervention should we roll out during the pandemic? And according to the World Health Organization, services that afford self-management that results in health promotion, peer support, maybe we can start a support group for persons living with diabetes, or disease management, so we can have contact between the client and the provider. Remote monitoring, I can be in Accolades, and he can follow my diabetes in New Providence. And engagement in the treatment, I could say to him, hey, I don't like that medication, it makes me feel off, and together me and the provider decide what is best. Next slide, please. And so I'm going to provide you with a couple of examples of what the PHA has rolled out specifically for digital solutions. We have rolled out in our primary care services patient-provider consults, where our physicians would telephone you, or they would use the .cme platform and have a conversation with you as to where you are in primary care. We have rolled out telemental health services, where our psychologists would give you a call, or you can call in at a call center, and those numbers are made available routinely. If you're struggling, you can give our psychologist a call. We have even done rehab services remotely, where we work with clients to ensure that they are not losing their mobility. And our employee health services have managed all of our positive healthcare workers remotely. The government of the Bahamas has also rolled out those virtual town hall meetings to address our mental health concerns. I believe the examples are for the elderly, for disabled, for children, any number of town hall meetings, and they were specifically organized to help us cope with some of what we're dealing with on a day-to-day basis. We've done webinars and trainings such as what we're doing now remotely. We've sent messages remotely, and we've launched, as I said before, dedicated hotlines that will link persons to appropriate services. So if you call and you say, I haven't had anything to eat for a couple of days, the call center has the ability to link you directly to social services, and they are able to go ahead and support what you need. Next slide, please. Back to the example of telemental health activity, those virtual town hall meetings. In the beginning, they were well attended, falling off a little bit now. We've addressed the mental health concerns of the elderly, the disabled, youth, and island specific. So whenever Bimini had a problem, we had a town hall meeting for Bimini, we had one for Grand Bahama, we had one for Lutra, and we're about to do one for Exuma. Next slide, please. Thank you very much. Any questions? Any questions?
Dr. Thompson, thank you for a great presentation and an overview of how COVID has impacted your institution. My question for you is, I applaud you for initiating the online services. Going forward, are these going to be expanded to be inclusive of all the departments or all the clinical areas, or is just going to be focused on these one or two areas as it is?
Okay, thank you for that question, Dr. Pakistan. The Public Hospitals Authority has been working with the Pan American Health Organization to ensure that the standards of practice that we're using for these digital services are in keeping with best practice, and we are looking into roll those out for all services. You would note that we had done a number of telemedicine pilots some years ago when the now Prime Minister was the Minister of Health. And that fell by the wayside, and as you are aware, technology moves quickly, and so the technology there is now obsolete. But there are services that we're looking to expand further. Again, we are in new territory, and so we want to make sure that we are in keeping with best practices. So yes, we are looking at expanding those remote services.
One more.
One more.
Sorry.
It's nice to be on the opposite side. What he hasn't told you is he was my lecturer in pharmacy, and I was doing pharmacy, and I was the person asking the question.
There have been rudimentary ideas and talks about a national health development plan. My question is, PHA as the responsible body for the majority of the health situation in the country, how does the policy that you make impact that strategic plan, or vice versa?
Okay.
Because we're not hearing anything about the plan, but we're hearing about your policy.
Okay, so the plan was set to be refreshed. The plan ended this year. It was set to, strategic plan was set to be refreshed or renewed this year. COVID happened, Dorian happened, so in the beginning of the year we were kind of focused on Dorian and how to respond to that. And by March we were dealing with COVID, still dealing with COVID. Based on what the Ministry of Health is saying, we are about to roll out a new plan. Hopefully we don't see too big of a third wave, and so we are set to roll out a national strategic health services plan. Our plan, the PHA also has a draft strategic plan, which speaks to some of this digitalization, but we can't roll it out until the national is done. and there will definitely be alignment. There is a move to ensure that digitization of services continue. If that's an answer. Any other questions?
We'd like to just say a special thank you to Dr. Thompson for an awesome job. I told you she would do it, and she did. So I just wanted to recap a couple of things that really got my attention. She spoke about the challenges that were seen at the PHA and specifically with the employees, the services. And then I was really impressed with the innovation that they put in place. Talked about rolling out the digital platform and to provide services remotely. We definitely in podiatry are looking forward to that because that is something definitely that can be used to save limbs and lives in our diabetics, because I'm sure once we are able to have the data, we will see that our diabetic services were significantly impacted as well. And then you also mentioned that looking at disease management in terms of a remote management of those services, and I think that would be fantastic because a lot of persons, like you said, didn't come because of COVID, but that didn't mean the diabetic foot infection wasn't progressing or didn't lead to an amputation or even an early death. And so we have to think of all of these things as we think of what is going on in the entire health system. How does that impact that on the individual? So thank you so much for coming and being with us, and we really appreciate it, and it's very enlightening. Thank you.
Thank you. Before I close, I want to say that we are currently working with the Pan American Health Organization to roll out self-management using remote tools, diabetes and hypertension. And so I'm going to draft you into that conversation as soon as we're closer. We're rolling that out.
Excellent.
Thank you very much.
Thank you so much.
And congratulations everybody on your third conference.
First virtual.